Hello, good evening, everyone. Welcome back to our IVF webinar. It's lovely to be back here once again with all of you and also Dr. Halyna Strelko. You can see her right here. Hello, Dr. Halyna. How are you feeling tonight? Hope you had a nice day and are ready to educate a little bit all of us right here. So, how is it going today?
Thank you. All is fine. The weather is not so good, but I'm ready to speaking. So hope it will be interesting. And first of all, I would like to thanks to all people to their time and their interest to this topic. And really, this topic is one of the most interesting in IVF branch. So we will try to show something interesting this
Definitely.
evening.
I already have seen your presentation. It's going to be an interesting case that you are going to present. But also, of course, Dr. Halyna will explain low ovarian reserve and what treatment options are available. So stay tuned. Just have a look at her presentation and what she has prepared for all of you. But afterwards, as always, there will be time for your questions. So remember, you can put those in the chat section and we will take care of all of your questions one by one after the presentation is over. And I just want to add that myivfenses.com, as you know, we are part of European Fertility Society, and we are here, well, almost every single day to provide you with some different topics. As you might already know, we are focusing this autumn, we are focusing on success stories. So we've been talking about advanced maternal age, recurrent miscarriages, but also as today, low ovarian reserve. And our main focus is to talk about real life cases. So every webinar will have some interesting cases to be discussed. And also, as you probably might have heard, there are some webinars that we are currently running also in Spanish and also in Italian. So if you haven't seen it and could also find it interesting and are able to listen to it, then definitely I can only encourage you to go to myivfenses.es or myivfenses.it, and there are some more events there as well. And that will be it from me at this point, okay? So remember, you can definitely ask your questions in the chat section later on, of course, as well. And let me also add that Dr. Halyna is the co-founder and fertility specialist at IVMED, which is located in Kyiv, Ukraine. And I will leave you to it, Dr. Halyna. You can start with your presentation. Thanks so much.
Thank you. Thank you. So today we will talking about poor ovarian reserve. First of all, I will present very interesting clinical case, and then we'll explain a little bit what is it poor ovarian reserve and why it is so important to measuring this ovarian reserve and why it is important to understand it. So let's move. We will talk today about the case of my patient, Katerina in Ukrainian. She was 29 years old when she became my patient in 2019. And her main clinical diagnosis was very poor ovarian reserve after chemotherapy. She has Hodgkin lymphoma in 2016, successfully treated, but after this treatment she lose mostly all her eggs. Before to start chemotherapy, she has done fertility preservation, not in our clinic. She has frozen 5 eggs, 3 mature and 2 and 1 not enough mature. But when she come in our clinic, she has IMH 0.2, and in ultrasound I have seen only one antral follicle and one corpus luteum. This is the structure which we can see after ovulation normally. Investigation not show something special. Only low ovarian reserve, infections were negative, coagulation test little bit increased fibrinogen, but it may be in such conditions. General blood test also normal, hormonal levels also normal. Her husband has a little bit decreased sperm quality, only 3% of normal morphology, and decreased motility, little bit low count of sperm cells, probably due to varicocele. This is the enlargement of vein of testis. And okay, we discuss what we can do in this case. Stimulation is probably useless because on only one antral follicle, so stimulation will not increase the number. So natural cycle IVF, and also thawing these frozen oocytes, fertilized all together and doing fresh transfer. And we have done like that. I receive one egg. We thawing 3 eggs M2 and 2 eggs M1. Then M1, our embryologists tried to maturate. They became M2, and we have done ICSI, but unfortunately receive only one blastocyst. Here you can see her embryological protocol. We receive fertilization in 4 embryos. Then only one was more or less good day 3, 8 cells. And then blastocyst type 4AB was transferred to patient, and unfortunately result was negative. So couple of months she has a rest, and then return to see me on day 5 of cycle, trying to receive one more egg. I have seen on day 5 dominant follicle, 23 millimeters, ready to ovulate. It is very early, but this is the problem of women with very poor ovarian reserve, that their follicles start to growing even in previous cycle, before menstruation, and at the beginning of the cycle sometime we can see this situation that they has 2-3 follicles, but one of them big, one of them average, one of them little, and finally we cannot receive more than one. So we decide not to take this follicle, waiting for ovulation, and I prescribe to her estrogens, because this very quick growing of follicles mostly depend on high FSH level. So with estrogens, we decrease FSH level. After ovulation, I add progesterone. And in 2 weeks, in the next cycle, at the beginning, we have seen 4 antral follicles. And we start the new stimulation, Clomid plus FSH, triggering with HCG, and this was very good result. We received 4 mature oocytes and 2 blastocysts. You can see the new protocol. Blastocysts of very good quality, 5AA and 4AA. One of them we have transferred to patient, and one was frozen. And we receive positive result in this case. In this slide, I would like to show you embryo. We have transferred one embryo. You can see hatchet embryo, 5AA, with very good developing internal cellular mass. From this part of embryo, normally after will formate the fetus, the embryo. And it is very interesting that here we can see that, and in this part of embryo, of course, we don't see that. But when we receive a result that I have done ultrasound, it was monozygotic twins. And after, she has delivery of 2 beautiful boys with good weight. And you can see in the picture, our treatment was very successful. So now let's talk a little bit about ovarian reserve testing and what we can do in such cases. Yeah. So what is it, ovarian reserve? This is the number of follicles and eggs in ovary in the moment of testing. There is a official recommended criteria to say that woman has a poor ovarian reserve. This is what we call Bologna criterion. In 2011, there was a big meeting in Bologna, European Society of Reproductive Medicine, and this was created the guideline to define the poor ovarian reserve. So, and it is interesting, you can see that in the first position it is advanced maternal age. Age, it is not related to number of eggs, but it is in the first place. Of course, it is very important, and we will see why. Also, one of the criterion, it is the previous poor response to stimulation, less than 3 oocyte in normal stimulation, or abnormal ovarian reserve test. So necessary to have 2 of these 3, and in this case we can say that our patient has poor ovarian reserve. So why ovarian reserve testing it is so important? First of all, because each egg in average have probability to give live birth is around 4-6%, no more. So more eggs we receive, more percentage of pregnancy we can have. Ovarian reserve permit to us to do some prognosis. For example, number of follicles, probability of pregnancy, which should be the starting and total dose of medication which we will use, success rate, and in some case, if we can see and explain to patient that probability of pregnancy is very, very low, less than 1%, okay, sometime we can move to egg donation. Or just opposite, if we can see that probability is good, okay, we can try once more. So you can see in this slide a lot of markers of ovarian reserve. So a lot of possibility to measuring this number of follicles and oocytes. In the first place, also we can see age. Then some hormonal tests like FSH, estradiol, inhibin, anti-Müllerian hormone, some dynamic tests. It means that we give something and then measuring what happened. Then biophysical tests like ultrasound. We can count number of antral follicles. Actually, our ultrasound machines are quite sensitive, and if we have follicles more than 2 millimeters in diameter, we can see them in ultrasound. Also important point, it is genetic tests, because in some cases women can have good number of antral follicles, but her receptors is not correct. They don't see FSH molecule or LH molecule. In this case, the response to stimulation will be much less than we expect. And of course, the most exact method is histological, so necessary to take some part of ovary, cut, and then see number of follicles. But okay, in normal life, we don't do that. So age, why age it is in the first place? Because we know that age of women is correlate with probability of pregnancy. Of course, necessary to say that chronological age has a limited ability to predict the response to stimulation. Recently, I had patient 42 years old, and I received 50 eggs. And sometime I have patient of 25, 30 years old, and I can receive only 1 or 2 follicle, only 1 or 2 eggs. So it is always individual, but in most of case, with the age, number of follicles decrease. But main cause of this marker was put in the first place, it is because on egg quality. The most reliable predictor of pregnancy rate and live birth rate, it is age and not the number of follicles. If we will take into account age with another markers, we will have always better prognosis than only with one marker. So main things that, okay, individually it is never possible to say exactly, but in most of case 42, 43 years old, this is the limit when we can receive live birth with own eggs. Mostly it is due to genetic problem of eggs. You can see in this slide that, for example, if we have a woman with average response like 7 till 10 eggs, before 39 years old, mostly 100% of this woman will have as minimum one genetically correct embryo. But if we have poor responders, 1 till 3x, 42, 43 years old, only 17% of embryo will have normal genetic and only 37% of women will have as minimum one genetically correct embryo. That's why age it is so important. Another marker of ovarian reserve is antral follicular count. It is the number of antral follicle which we can see with ultrasound. It is quite simple. This is a very important marker, has low variability between cycles and between performers with good qualification as well. If we can see the relations between antral follicular count measurement and between number of eggs, poor response, ovarian hyperstimulation syndrome, we can see very high sensitivity and specificity. So it is very good method. And it is always good to use at the same time anti-Mullerian hormone measurement. Why IMH is the best marker of ovarian reserve testing? Because we can see if we compare, for example, IMH with FSH, and we can see here in the bottom age, yeah, FSH is normal, 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 and then near 50 years old, when we have mostly zero ovarian reserve, it is quickly go up. So yesterday it was okay, and today it may be absolutely out of normal range. So difficult to understand this moment when we start to lose really our eggs with FSH. The same with estradiol and progesterone, normal, 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 and then when mostly we have menopause, okay, drop down. With IMH level, we can see that this curve is decreased progressively, and it permits to measuring at time and at the moment the situation. If we compare the prediction of live birth rate in fresh cycle, antral follicular count, anti-Mullerian hormone, and age, we can see mostly the same result. With in this three curve, age give the more reliable result. Anti-Mullerian hormone level correlate well with the number of follicles which we can receive. So we can see in this slide more or less the number with some amount of IMH. But when we measure in IMH, it is always necessary to thinking about some kind of laboratory variability of this measurement. It may be due to pre-laboratory preparation of blood, in some temperature condition, in some laboratory tests which they are using. And in some cases, real situation may be twice or even 2.5 times different than you have in your plasma. So it is always important to have 2-3 different methods of measuring of ovarian reserve to be more exact. So always patients asking which is the normal IMH level. So now there is no, how to say, normal level. It is depends on goal why we are measuring IMH level. If a woman has all children which they would like to have, no thinking about stimulation, she has 43 years old and her IMH level is 0.2, it is absolutely normal. But if she would like to be stimulated, we can say that it is low ovarian reserve and this level is abnormal. So more correctly will be to talking about the possibility to receive some amount of eggs according the IMH level. If we have less than 1, it is considered as reduced ovarian reserve. If we have less than 0.5, it is very reduced ovarian reserve. From 1 till 2.5, it is more or less okay. It means that we expect to receive like 10-15 eggs. More than 3, we expect to have high response, and more than 3.5, maybe even risk of ovarian hyperstimulation. So, but it is only in relation to further stimulation. I would like to talk a couple of words about the new theory of follicular waves. Why it is important? Because previously doctors thinking that follicles growing constantly, but the last time it was discovered that follicles growing by groups, by waves, and in some case during one cycle we can have 2 waves, in some case we can have 3 waves. And according this, sometime will be good to adopt our protocol of stimulation and found the moment when the wave of growing follicle will be the most important. And sometime it may permit to receive more eggs. So you can see in this slide the change of FSH level during the cycle, and we can see the growing follicle. That's why we have used these estrogens in our clinical case. After ovulation, it decrease FSH level and decrease little bit the difference in size of follicles. Sometimes we can see during the cycle 2 waves, sometimes we can see 3 waves, but less ovarian reserve we have, more difference in size of follicles we can have at the beginning of cycle. And this is one of the biggest problem with patients with poor ovarian reserve, that they come first, second day of cycle, and we cannot start the stimulation because we can see follicles, but all follicles has different size. And sometime we can start stimulation in second phase of cycle, sometime just after ovulation. So looking for this wave and trying to find the best moment to start the stimulation. Now the cryopreservation of embryos, of oocytes, working extremely well. In our clinic, we are doing mostly 90% or probably 85% of all transfers of embryo in cryocycles. survival rate is 99 point something, so no risk that embryo will not survive the freezing. And it permits to start stimulation mostly any day of cycle, then freeze, and then waiting for the optimal moment to thawing and transferring. In this slide, you can see the comparison of stimulations when we have luteal phase estrogen priming. It means give estrogens after ovulation, which can decrease little bit FSH level, and like that little antral follicles growing more homogeneous. You can see that number of follicles which we receive in this case is more important. The maturation rate is higher. The clinical pregnancy rate is mostly twice higher, as well as with birth rate. So it may be sometime good method to receive more follicles and more eggs with patients with poor ovarian reserve. So, how to improve the result of stimulation for poor responders? Of course, a lot of method describing, and we try to use all this possibility with our patients. But quite often we use methods mentioned in this slide. We add estradiol in the luteal phase, like that receive more homogeneous cohort of oocytes. For stimulation, quite often we are adding recombinant LH because with poor ovarian reserve and after 35 years old, quite often woman has not enough LH during stimulation, especially in case when we're using antagonist of GnRH. Also, we are using growth hormone. We have talked about in our last previous presentation. Growth hormone improve the quality of eggs and improve sensitivity of follicles to stimulation. Also, sometimes we can use like preparation androgens, aspirin to improve blood circulation. And it is important to use the specific protocols of stimulation, as we describe. Stimulation from second phase of cycle, duo stim when we have when we can do two stimulation during one cycle, and stimulation after estrogen primary. Also, natural cycle IVF may be very helpful, especially in case when we have only one follicle and no need to stimulate, only waiting when this follicle will grow enough, and then triggering and take oocyte. Oocyte cryopreservation in case of natural cycle, for example 3-4 cycle, we're collecting oocytes and then doing fertilization. And one of the last method, PRP, we're using also. Me personally don't see very important result with this method, but also it depends. Sometimes it may improve the number of follicles. So, poor ovarian response, unfortunately, it's a very typical situation in reproductive clinic. And ovarian reserve testing is one of the important part on infertility evaluation, because it permits us to understand what we should do, how quickly we should do, and which protocol, which medication we should use, and which prognosis we have. The essential markers of ovarian reserve are age, anti-Müllerian hormone, and antral follicular count. IMH indicate only number of antral follicles, not related to quality, but age is most important predictor of quality of eggs. And of course, in such difficult case, we should use individual approach for each patient because it is essential for the successful treatment. Thank you for your kind attention, and I will be happy to answer all your questions.
Wonderful. Again, thank you so much indeed for explaining all those details. First off, with the case study, and of course, afterwards, explaining how it works, what can be done. And now there are some questions. There are some patients here seeking some advice. As you can see, a number of questions already. So,
Yeah. I will go to top and
sure, I will show you the first one. Don't worry, right here. Okay,
Please, like that,
perfect.
because it is very little letters.
Sure. I will read it for everyone just in case as well. I have just turned 38, had my first ICSI cycle due to male factor mobility. I had 12 follicles, retrieved only one mature egg, empty follicles. Other follicles were empty and cysts. Been recommended mini IVF next time. AMH over 8. And I also have a fibroid, was told low reserve in one ovary and other formed cyst. Anything you can advice.
Okay, thank you very much for your very interesting question, because it is not very common to have 12 follicles and only one mature egg. And IMH over 8, not mention it is picomole or it is nanogram, because for picomole, of course, it is low ovarian reserve. For nanogram, it is very high ovarian reserve. In this case, mostly the problem of maturation, probably, because 12 follicles, it is good number. The problem of maturation may be due to different reasons. One of the reason it is low dose of stimulation. So follicles was not enough big at the moment of triggering. There is no information in this question, but probably they was like only one follicle 18 millimeter and other was like 14, 15. Second reason may be not good triggering. Sometimes patients not react well to agonist triggering. It is around 5% of patients. Sometimes patients not react well to HCG triggering. It is mostly less than 3% of patients, but it may occur also. Also, it may be the problem between the triggering and egg retrieval. Normally, it should be 35, 36 hours, but individually, it may be a little bit more. Individual maturation may take more than this standard 35 hours. Also, maybe the problem of some defects inside of oocyte, and it is not related to medication. It is like internal problem. So, of course, for the next stimulation necessary to change triggering, probably waiting a little bit more between triggering and egg retrieval. To see about stimulation, probably use growth hormone. Sometime in such cases, I'm using growth hormone and we receive a little bit more eggs and more mature. But it may be also some problem inside of follicle and oocyte, some biochemical problem, and in this case, medication will not be able to resolve this problem.
Thanks so much, of course, Sam, for your first question. If you have any follow-ups, additional information like picomos or nanograms AMH, yes, just let us know. Okay, we can always go back, but let's go with the next question, and I will go back if needed, of course.
Okay.
And there are like 3 parts of the question, okay? So let me just go here. What is the best fertility protocol for 42-year-old with low AMH and low ovarian reserve who is a poor responder? Is IUI better than IVF? AMH is 0.2. Okay, that's it.
Okay. Thank you for your question. IUI, okay, it is not better, it is not worse, or it is different method. IUI is the method when we are using sperm after special preparation and put inside of uterus the moment when we expect to have ovulation. The probability to have pregnancy even at like 30, 35 years old is mostly not exceed 10%. Uh, Theoretically, it may work, IUI, but the problem with IUI that it is difficult to analyze what happened because we don't see egg, we don't see embryo, we don't understand if this embryo reached blastocyst stage, and that's why it is difficult to say why pregnancy does not occur after IUI. One IVF attempt give mostly the same probability of pregnancy as 1 year of another kind of treatment. So when we are talking about 42 years old, probably better to move to IVF because, how to say, no time to waiting results with more efficient methods. About the protocols, necessary to see the antral follicular count at the beginning of cycle, and if we have 3, 4, we can try the stimulation like clomid or letrozole with FSH because sometimes it helps to stimulate more follicles than standard FSH. Sometimes we can use high dosage FSH, but if we can see only 1 or 2 follicles, probably better to follow them with natural cycle, or probably give some estrogens and see after ovulation in this cycle or in next cycle, and sometimes we can see more antral follicles, and this moment we can start stimulation immediately.
All right. Again, thanks so much indeed for yet another question and for your help with that. Just let me go to follow up from this patient. Just a second. Being told I can't use Clomid because I have hypothyroidism.
Mhm. We can use letrozole. It is the medication which also decrease estrogens and increase FSH, own FSH. So normally
Okay.
we are using such medication for stimulation as well.
All right. Thank you. Indeed. And now I will go to the previous patient, Sam, okay, as she has added some more information. So I was given 250 gonal triggered start at day 7, then 36 hours later retrieval. AMH is 8.4 picomoles. I was
Picomol.
told fluid in follicles not right and due to cyst forming.
Um, Look, every follicle has fluid inside. We call follicle name cyst in case on we don't receive eggs, but normally all developing follicle has oocyte. So as for me, triggering day 7 is a little bit early, but necessary to see all protocol, all size of follicles, probably estradiol level day of triggering. In this case, I can say something more exact. What you describe, okay, IMH 8.4 picomole, it is decreased ovarian reserve, but 12 follicles, it is a good number. So as I have mentioned, sometime we can receive number of IMH which is not exactly correspond the plasmatic level due to some laboratory condition. So as for me, in your case, probably necessary to change medication. You can use, for example, Pergoveris. And this is the medication where you have not only FSH, but FSH plus LH. Or urinary gonadotrophin sometime may be also useful. because they contain HMG, which has the same activity as LH, and also probably stimulation should last a little bit more than 7 days. But okay, necessary to see all protocol in details.
And of course, thanks so much. And yes, Sam, remember that in order to properly, cancel, I'm sure that Dr. Kakalina would need more details. So remember, you can definitely get in touch with IVMED Clinic and the team. I'm sure they will be happy to help you with some more details here as well. Okay, and let me go to the next question. We have a shorter question here. Can DHEA help increase AMH and outcome of fertility treatments?
Good question. Thank you very much. It was around 10 or maybe 12 years ago, very popular to prescribe IMH. There was some publication in United States about one gynecologist who, following women who start the stimulation for fertility preservation and receiving DHEA, and couple of months later he received a lot of follicles, a lot of eggs, and okay, it was very, very popular. But after, scientific works does not show very, very important influence of DHEA on follicle number, and now it is mostly transdermal testosterone proposed for that. And it seems that it is working better than this molecule.
All right. Again, thank you for your question. Again, interesting question, sure.
Yeah.
Next one will be a bit of a longer with some details, and there are two questions in this. So let's have a look. 41 AFC, 10 AMH, 23 picomoles, FSH, 7 CT2, a Poseidon to be hyper responder, 4 standard antagonist cycles with 300 IU FSH, 8-9 oocytes at OPU 6-7M2, all fertilized by ICSI, one morphologically good, untested blastocysts on average, no sperm issues, both karyotypes normal. First question, how to modify stimulation protocols to increase oocyte output and continue with ONEX for how long, or start preparing for donor eggs?
Okay, very good question. Thank you very much. Mostly this situation is more or less typical with patients after 42 years old. It may be several problems in this situation. First, okay, a low blastocyst formation rate, 7M2, all fertilized by ICSI, and only one morphologically good blastocyst. It means that embryo don't developing well and don't go till blastocyst stage. It may be due to some genetic problem inside of oocyte, so abnormal nucleus, but also it may be due to abnormal cytoplasm of oocyte. We know that after 38 years old, number of mitochondria inside of oocyte decreased dramatically, mostly twice when we compare with 30 years old. And in this case, oocyte has no enough energy to moving till blastocyst, to developing well. Also, second problem may be lack of ions of calcium inside of oocyte. Also, it is quite often with age and with decreased ovarian reserve, and all intracellular process related to increase of ions of calcium. So in your case, I think will be more promising to change embryological strategy rather than stimulation. Okay, with stimulation we can improve a little bit your response with growth hormone, with higher dosage, with adding recombinant LH. Probably we can do what we call double trigger HCG plus agonists. But in this case that you describe, the main problem, it is the low blastulation rate. So as for me, this is raising the question of embryological strategy. Continue with own eggs. Okay, depends if you can talk in with your laboratory and try to modify the strategy. For example, using piezo activation, using calcium ionophore, using probably spindle transfer, and in this case to see blastocyst formation rate. Also probably will be good to see if your blastocyst is genetically normal, and then take further decision. Also possible to talking about egg donation.
Thank you so much for your detailed question. Of course, thanks so much, and thanks for the advice here. And as you can see, Dr. Galina, lots of questions are coming up. Okay, let me go to the next question we got from Karen. If the FSH is low anyway, is there any negative impact of priming with estrogen? My level is around 5.2 for FSH, and I have primed with estrogen, and the follicles are still different sizes. I have more smaller follicles that are too small to stimulate. I didn't have the very small follicles when I did not use priming.
Yes, probably when your FSH level is more or less normal, priming will not be very helpful, but in this case you can try to start the stimulation just after ovulation, 2-3 days after, just when second wave of follicle growing start, and probably in your case it may be helpful.
Okay, thank you. Karen has a few more questions, so let me go straight to this one as well. Just a second. Yeah, here it is. Can the result of luteal phase stimulation be as effective on its own as doing luteal stimulation following follicular phase stimulation?
I don't understand well. So the question is if luteal phase stimulation has same effective as follicular phase, yeah?
I believe so. But
So,
Karen, if you can clarify if that's correct, yeah?
yeah, probably, yeah. So, these luteal phase stimulation protocols finally this has the same results as follicular phase protocols in number of eggs, quality of eggs, and length of stimulation, general number of FSH, total dose. And it was start when doctors proposed to do fertility preservation for cancer patients, because cancer patients come, they has very short period of time when it is possible to stimulate, 2 weeks, 3 weeks, and necessary to start immediately because no time to wait. And for this category of patients was started different kind of intervention, different kind of protocols, and luteal phase protocol, mid follicular phase protocol, and finally it was shown that mostly all give mostly the same result. So now luteal phase protocol, it is more or less standard protocol for women of decreased ovarian reserve, and we are doing what we call duostim. First stimulation from the first day of cycle, then ovulation, egg retrieval, and in 2-3 days we start second stimulation. So like that we are using twice number of egg. So answer is yes, it is mostly the same.
Okay, thank you for
Only
the
we cannot do
clarification.
the fresh transfer in this case because endometrium is not ready.
Okay, sure. Thank you so much. And if there's anything else you'd like to add, you know what to do. And let's have a look. Okay, I just need to go back to all the questions here. Okay, actually, Karen has another question here. How long is recommended to take Clomid, letrozole with FSH to help with the small follicles?
Thank you for your question. We are using normally during 5 days. And then stop, because these molecules decrease the level of own estradiol, and as we know, the level of FSH is regulated with estradiol, so less estradiol we have, higher FSH we will receive, and like that we will use own FSH, which will increase, and adding FSH with injections, and like that receive more high in circulation and more effects on stimulation.
All right, excellent. Thank you so much. And one more from Karen, okay? If you can perhaps help with that. It happens a lot, right? How do I convert picomoles to the other measurement nanograms, right? My AMH is low at 6.2 picomoles, and I would like to convert.
Okay, with pleasure I will help. Necessary to divide by 7.14. Picomole divide by 7.14 and you will have 12. Divide by 7.
Okay.
7 something, 7.14 it seems to me. So 6.2, it will be 0.8, something like that. Yeah, it is not very
Nanograms.
high. Yeah, in nanograms.
Okay. Thank you for the clarification. I think that many times it is confusing, of course. So thanks for the explanation, definitely. Okay, more cases are coming up here. Okay, so let me just go to the next one. This time from Christina. I have two parts. Okay, so I will show you the first one. I am 41, AMH 2.36 picomoles, have frozen 2 embryos. Do you recommend to continue with freezing embryo for 1 more year before I proceed with the transfer, or try with the existing embryos, and if it's not successful, you use egg donor? I froze the embryos at 40, and sorry, just let me...
40 years old.
Oh yeah, my AMH 3.59 last year in March. Yeah, this is the additional information.
Okay, very good question, but okay, this raises probably philosophical question than medical, because of course, if it is possible to continue with receiving eggs, it will be good, because at 41 years old, probability that in this case egg will have normal genetic is quite good. But if you will try to do the same in 43, 44 years old, this probability will decrease dramatically. So if you have possibility to freeze extra 2-3 embryo, it will be good idea. With IMH 2.3 picomole, probably you will have only one follicle during the cycle, so it will be natural cycle probably. So during 3-4 cycle, you will be able to receive 2-3 eggs and extra 2 embryo probably. So if you have this possibility, I think will be good to do that. But okay, probably you have another plan, so it is always difficult to say, because nobody know how it will be. Yeah, nobody know if will be successful. Okay, yeah, yes, one egg usually retrieved. Yeah, because IMH level unfortunately is not very high.
Thank you again for sharing your advice here. Next question we have. Sorry, just need to have a look. Yes, there's a thanks from the patient for you right here. Okay, and let's have a look. Sebastian has added this question. I just need to... How does your estradiol addition in the luteal phase? Which preparation do you use for how many days? Not sure here.
Okay, more or less understandable the question. Thank you. So, the idea of estradiol using is first to decrease little bit FSH level in second phase, and probably it will regulate little bit these waves of follicle growth. And second point that sometime little amount of estrogens can give anti-apoptotical effects. It means that follicles, even when menopause establish, they still continue to growing, but they stop in some point of their development. And when we add little amount of estrogen, of androgen, or some medicine which improve ovarian blood circulation, it may decrease these apoptotic reactions, apoptotic effects, and in couple of months we can see sometime increase the number of antral follicles, because even when patient come to see me and it is mostly established menopause, after 2-3 months of replacement hormonal therapy, which consists on 2 milligram of estrogens and 10 milligram of progesterone, sometime we are able to receive 1 to follicle, 1 to egg. Okay, this effect not last during the year, as it is probably 1-2 years after the beginning of menopause or after the serious decrease of ovarian reserve, but sometime it may be helpful.
Sure. Thank you so much indeed. And let's have a look. I am just replying, of course, in the chat section, but I now see the details. Apologies, but let me go to the next question from Karen. We have, with AMH of 6.2 picomoles, what would be the typical rate of follicles egg retrieval?
Oh, sorry. We'll see. With AMH, what it should be around 5, 6, 7 eggs. But once more, sometimes the level of FSH does not realistically relate the ovarian reserve. Sometimes we can have better situation than we expect to have with FSH level, and sometimes worse. So necessary to see also antral follicular count. But if it is realistic situation, it should be something like 5, 6 eggs.
Okay, perfect. Thank you for that one as well. And let me go for this question. Do you feel PRP stimulating ovaries due to very low 25.8 FSH? 5480? I'm not sure here, sorry. Can you?
If it is FSH 54, it is quite high. It means that estradiol level is low, and probably cycle is very irregular, and probably some cycles are without follicles, so 2-3 cycle without 2-3 months without menstruation. In this case, okay, we can try PRP, but I prefer to prescribe replacement hormonal therapy first. Something like coenzyme Q10, something like molecules which improve blood circulation. And also we can do PRP. Of course, it will not be very, very successful, because due to your hormonal level, ovarian reserve is really poor. No eggs, yeah. But okay, we can try like that.
Okay, again, of course, thanks so much indeed for yet another answer. We will be slowly coming to an end. There are some questions left, of course, but if you have more, this will be the final call for them. So just go ahead, type those in. And as you can see, another thank you for helping out with that. And now I will go to the next question. There are details and of course a question, 2 parts. I'm 42, FSH 11.7, LH 4.8, estradiol 3.3, testosterone 39, SHBG 62, free androgen index 0.6, prolactin 188, TSH 1.3, and T4 16.8. And the question is right here: what will be my best treatment option, donor or own eggs?
Okay. Look, the problem that according the hormonal level, of course, is possible to receive eggs. The main question it is the quality of these eggs. Quality, as we have mentioned, depends on age much more than on IMH level, etc., etc. So mm, necessary to see if you have done previously 5-6 stimulation and mostly never has normal embryo, good quality blastocyst. In this case, probably will be better to move to egg donation. But if it is your first stimulation, as for me, better to try as minimum one time with own eggs, because there is no possibility to predict quality of eggs and embryos with hormonal level or whatever analysis we can do. Only we can see this quality after egg retrieval. Till 43, rarely 44 years old, we can receive live birth rate with own eggs. After, it is mostly impossible.
And Mosbar, thank you for yet another advice. And as you can see, there's a thanks for your answer. And that might be our final question for today. But of course, we will see. Let's have a look. Sebastian has added one more question. Which estradiol, preparation do you prescribe in the luteal phase for how many days? Progenova 2 milligrams for 10 days.
Sometimes it is 2 milligrams, sometimes more, depends on how many antral follicle we can see, and also weight of patient, because if weight is not big, okay, we can give less estrogens. If weight is more important, it is dosage should be higher. So it may be from 2 till 6 milligram.
Excellent. Thanks a lot for that. And let me go for the next question. Okay, it's additional question from Natalia. So let's have a look. So of 6-8 oocytes fertilized, normally about 2-3 arrest by day 3. And would better lab techniques help piezo or CA if poor egg quality?
Yes, sometimes it may be helpful, and we have quite a lot of cases when we has mostly total 3-day development arrest, and after piezo activation, we has good number and good quality of blastocysts, and I can show this case probably some of next webinars. It is really very interesting. Even we try to make like video how ions of calcium come inside of oocytes after this piezo activation. We have specific camera and we can see this. It is really fantastic. So sometimes it may be helpful, but not in all cases, of course. Depends on which kind of problem there is in cytoplasm. So impossible to say that in your specific case it will work or will not work. But if we take, how to say, 100 case like that, probably 1/2 of this case will be better result with piezo activation with calcium ionophore.
All right. Thank you for yet another explanation indeed. And again, Natalia has said thanks a lot for your answer. Okay, and one more question we have here. If estrogen priming helps the follicles, what would then be the benefit to take Clomid letrozole to help small follicles if these medications reduce estrogen?
Excellent question. Thank you very much. It is, each medicine in the right time. Yeah. So estrogen priming, effects of estrogen priming is to, how to say, to make follicles more homogeneous. Yeah. The problem of beginning of stimulation in patients with poor ovarian reserve that they come day 2 or day 3 of cycle, there are follicles, but follicles has different size, and when we start normal stimulation, in 5 days one of them are ready for ovulation and other 3 or 4 are only start to growing. Yeah, and this is the main question, when to do the egg collection, because when we are waiting these little follicles, these big will be post mature or ovulate, so always difficult. So the estrogen priming may be helpful to make this cohort of follicles more homogeneous. What about Clomid and letrozole? It is another story. To make follicle growing, poor responder or normal responder, we should increase basic FSH level in 10 or 20 or 30%, better to 30%, but as minimum 10% on basic level. Each ampoule, each medicine which contains 75 units of FSH increase basic FSH level less than 0.8 till 1, so not very high. So if basic FSH level, for example, like 12 or 10 or 11, 30% it is 3-4, so we should give 5-6 ampoules of FSH, so very big dosage, and sometimes it doesn't work. So Clomid or letrozole helped us to increase own FSH. We decrease for short period of time own estradiol, and your body produce much more FSH this moment, and we add in extra FSH from outside, and we receive this increasement of 30-40% easily, and not with 6, 7, 8 ampoules per day. This is the main idea.
Okay, once again, thank you so much. Definitely interesting. And I guess we could explore it even more and more. So as you can see, of course, there's a comment from Karen. Thank you very much. Interesting indeed. And that looks like that was our final question. So thank you so much for your incredible questions. As always, very detailed ones, but that's what we really want. That's what we want to focus on. And I do believe that Dr. Halyna was able to help you out with the answers. Dr. Halyna, thank you so much. It's our second webinar, and it's great to have you back. And I can only tell you that Dr. Halyna will be back. So there are some more events coming up, and she will be back with some more details on genetics this time, right? It will be on the 16th of October, if I remember correctly. So of course, you can already sign up. This event is already available, so I can only encourage you to simply go ahead and register. And well, as you can see, plenty of thank yous are coming up for you. So before we finish, anything else you would like to add?
Thank you very much. Questions were really interesting for me, sometimes even difficult to answer. So thank you for your time, thank you for your interest in this topic. Hope we has interesting 1 hour, so we'll be happy to see you again.
Sure. Thank you so much. And as I can see, there's one more comment right here for you. So thanks so much indeed. And It's definitely an interesting session. So remember that if you would like to get in touch with Dr. Halyna and her team at IVMED, I'm sure they will be happy to help you out. You will be redirected to Dr. Halyna's profile on our website. There is an option for you to get in touch with the clinic as well. And of course, remember it has been recorded. You will be able to have a look at this. It will be available tomorrow on myivfanswers.com and our YouTube channel. So I do hope to see you back here. As you know, there is another webinar on Tuesday. So I do hope that you will be able to join us, another topic, another cases. So enjoy your weekends. It's almost there. Thank you so much, Dr. Halyna. I know that we will see each other very soon. I'm already looking forward to this. So thank you so much for tonight. Take care. And see you soon.
Thank you for technical support, for all support.
Anytime.
Yeah,
Thank you so much.
Have a
Bye.
good night. Bye-bye.